Good afternoon and welcome to the 2009 Alice Louise Reynolds Women in Scholarship Lecture. I am Brian Champion, Coordinator of Library Lectures and Chair of the Library's Department of Social Sciences and Education. It is our distinct pleasure to have with us today Professor Ramona Hopkins from the Department of Psychology, who will deliver an address entitled, "I Just Can't Think Straight, Critical Illness and Why the Brain Matters." We will hear more about Professor Hopkins in a moment. The Alice Louise Reynolds Women in Scholarship Lecture is a memorial to one of BYU's most outstanding female scholars. Professor Alice Louise Reynolds was the first woman to teach college-level literature classes at Brigham Young Academy. And when it became BYU at the dawn of the 20th century, she became the first woman to become a full professor. The current Harold B. Lee Library can trace its beginnings to a committee on library development and cultivation on which Professor Reynolds served, first as a member and then for 19 years as chair. As a devoted teacher of comparative literature, she dedicated her efforts over many years to fulfill the dream of a large and comprehensive library at BYU. For example, she was instrumental in raising funds to purchase all 1,200 volumes of Provost Judge J.W.N. Whitecotton's large and diverse personal library, which was the nucleus around which the Harold B. Lee Library has grown. At her death in 1938, the library had expanded to 100,000 volumes, which were the seed of our present 4.3 million volumes. Today's library stands as a perpetual memorial to her vision and her dedication. To honor this remarkable scholar, teacher, and friend of the library, the Alice Louise Reynolds Women in Scholarship Lecture was established, recognizing the contributions of outstanding female scholars at BYU. We have designated room 3420 in the library as the Alice Louise Reynolds Conference Room, in which hang framed posters of the Women in Scholarship lecturers since 2004, as well as Professor Reynolds' portrait. It is through the generosity of the now defunct Alice Louise Reynolds clubs and the current Friends of the Library that an endowment for this lectureship is made possible. Following Professor Hopkins' remarks today, we will be pleased to have a brief question and answer session. Now to today's featured speaker. Professor Hopkins is one of us. She received an associate's degree in nursing at BYU in 1975 and a BS in nursing at Westminster College in 1988. In the 1990s, she attended the University of Utah, where she was awarded an MS degree in 1992 and a PhD in 1996, both in psychology. And she returned to BYU in 1999, where she began her career in the Neuroscience Center and in the Psychology Department, where she is currently professor and chair. Her research is focused on the consequences of brain injuries following hypoxia or ischemia, and on the role of the hippocampus in memory acquisition or loss. A prolific author and co-author, she has published over 40 scientific or medical articles on brain functioning, and her contribution to the psychology and neuroscience disciplines is extraordinary. Not only is she a thoughtful and thorough scholar, she is well respected as a humane teacher, just the sort of professor Alice Louise Reynolds hoped BYU would have. It is a great pleasure to welcome today's Alice Louise Reynolds Women in Scholarship Lecturer, Professor Ramona Hopkins.
Well, thank you for this great honor to be here. What I've learned about Alice Louise Reynolds is quite impressive, and I hope that I am half of the woman that she was. She made quite a contribution. In talking about the brain, just to give some of you that aren't neuroscientists some basic background about the brain. So this is a human brain, and this is the front of the brain, the back of the brain, and this is the temporal lobe. So this is the part that you can feel right under your temporal bone in your skull. This is actually a colored MRI picture, magnetic resonance imaging, where they're actually taking pictures of the brain. This is a section right through the middle of the brain. If we split your head in half and opened it up, you can see the front of the brain here. Here's the nose. This is the corpus callosum that connects the two hemispheres of the brain and the back of the brain. And just to give you a sample of some of the complexity and how the brain is interconnected, so you can start understanding why some parts of the brain might not function after particular types of events or injury. These are individual neurons. And so this is one neuron. There's like 3 neurons here, 3 neurons here. And all these fibers that you can see coming out are connections that connect one cell to the other in the brain. You have 100 million neurons and 10 times that many support cells in the brain. And if you look at this in just 2 millimeters high and 0.5 millimeter in diameter, in a rat brain there are some 10,000 cells connected by 5 kilometers of fiber. And if you think about the complexity of that interconnecting in the brain that allows you to do everything that you do, including thinking, memory, moving, vision, seeing, hearing, it becomes quite impressive. This is actually in that temporal lobe I showed you. This is a structure called the hippocampus. And the hippocampus is critical for your ability to learn and remember new information and then store it into your long-term memories. And so you can see it as sort of a C-shaped structure, and this has been diagrammed down in a human brain. And this picture is the same region of the brain, but shows you blood vessels over the hippocampus. This is a part of the brain that has some of the fewest number of blood vessels, talking to you about why oxygen and glucose delivery to your brain is incredibly important. So if this is an area that has some of the fewest or the farthest from your heart, and you have this massive collection of blood vessels, why oxygen and blood delivery to the brain is so important. I'm going to talk a little bit about critical illness. A lot of my research is in medical disorders. And in critical illness, patients come in for a variety of reasons at a variety of ages. This is a typical ICU bed. This was taken at LDS Hospital. Now my research has moved to Intermountain Medical Center. But you can see there are large numbers of life support keeping this patient alive. So we have machines to help them breathe. We have machines to give them drugs to keep the heart rate and blood pressure up. We're measuring every vital function. And people can end up in the intensive care unit for a whole host of reasons, including trauma, car accidents, or pneumonia can move into critical illness. You can have heart effects and move into critical illness. You can end up from a minor surgery, ending up in the critical illness and being very sick. So why is the brain important? Well, people believed that the brain was protected by the blood-brain barrier. And then there are a bunch of autoregulatory mechanisms to try to preserve the brain. But if you go back and think about the picture I just showed you of that patient, every organ system in the body has taken a huge impact from the illness, and the brain is no exception to that. These protective mechanisms get overrun, and so they get overrun from infection, which we call sepsis, which is a systemic infection throughout the blood that affects every organ system. It's affected by lack of oxygen. You can see that the blood vessels get leaky and those protective mechanisms fail, and so the brain can be easily damaged in individuals with critical illness. This is a study coming out at the University of Chicago, and they were using a very crude measure to look at neurologic function or brain function. It's called the Glasgow Coma Scale. And a score of 15 is perfect. You're awake and alert. Everybody in this room, I hope, has a score of 15. And if you have a score of 3, which is the lowest score you can get, you're in a coma and very severe. And what they did was measure this in patients that were in their ICU. And I've highlighted the red boxes here. So the lower the score went, and so increasing is lower scores in this case, there was an increased risk of death if your brain function was impaired over time. This is 30-day mortality from the time you come into the ICU. If you look at just, again, the same Glasgow Coma score and look at whether the score improved, no change, or worsened, you actually had a higher risk of death if the score didn't change or continued to get worse over time. And so this very crude measure started to suggest that the brain wasn't protected in critical illness. So we were very interested in what the brain did. This is one of my colleagues at Intermountain Medical Center who's the first author. And all we did was look at through records to see how many patients in the intensive care unit that had brain imaging had any changes. So we started with almost 800 patients, and then there were about 300 that had brain scans, but we excluded people that we thought had a known reason to have brain injury, which included like trauma or Alzheimer's disease or a prior stroke, and ended up, and we were only looking for people that got a scan because they wouldn't wake up for whatever reason in the ICU once they came out of their medications, they wouldn't wake up. And here's what we found. In these patients that won't wake up, this is a normal brain scan, and these dark structures are the ventricular system. They create cerebrospinal fluid, the fluid around your brain. And this is a normal size. So here's the top of these are the front of the brain. This is the back of the brain, and it's about halfway down, if we were just going to sort of take a look about halfway down. And what you can see is the ventricles in these patients are much bigger than they are in a normal patient, indicating that we're losing brain cells, and we call this loss of brain cell atrophy over time. If we looked for changes in the white matter, those fibers, the connecting fibers between the cells I showed you, they have a coating on them to insulate them called myelin. It shows up white. These are normal brains, again, the front of the brain and the back of the brain, and these bright spots that I put the arrows on are changes in the white matter, which means it's disrupting the connections between different areas of the brain. And we also found people that had new ischemic lesions. You'd think of these as strokes. So this is a person that came in, was normal before they got into the ICU, and had extensive damage, all these bright areas in the brain. These are the temporal lobes on the right and left side. This is the brain stem coming down. Here's the ventricular system that we looked at before. So this individual had a very large stroke after they were in the ICU, and unfortunately did not survive. So back longer than I want to think about, we proposed that we study brain function or cognitive function in patients that were in the ICU. And one of the things that I'm going to show you is a case that I've been involved with that was actually not done here in Utah, but at Vanderbilt with my colleague Jim Jackson. And this is a 49-year-old female who has a degree in mathematics. She was a corporate manager, no significant psychiatric history. She was in good health, no prior cognitive problems. She got pneumonia, was hospitalized from the pneumonia progressing, was eventually transferred to a level 1 trauma center, which would be like Utah Valley Regional Medical Center or Intermountain Medical Center. She was admitted to the ICU. She had to be put on mechanical ventilation, the machines that breathe for you. Within 48 hours, she was going into organ system failure. Her kidneys failed. She was on a ventilator for over a month. She was in the ICU for 37 days, the hospital for 43 days. Then she went to a medical ward and eventually went to a rehabilitation unit and went home. This is a very unusual case because before she got sick, she'd had IQ testing or intellectual function testing. And on the test that I'm showing you here, it looks like this line slipped down a little bit. It should be right at 100. But that's an average IQ, and 15 points on either side is normal. So she was actually, the light blue bars are her pre-sickness intelligence score, and her IQ was about 130. So she was quite a bright woman, which would make sense given that she was a corporate manager. And this one is a verbal test. This is performance, and this is the total IQ score. And then you can see that we gave her the same IQ test after she'd been in the ICU. Her IQ dropped. It would still be considered normal. And then at 3 years, or 3.5 years, it had improved slightly, but never back to the pre-sickness level. the thing that's important about this is in all of our studies I'm going to tell you about after this, we would not call her as a patient that had cognitive impairments. We would say she was normal. But you can see, because we had this pre-illness data, that she had a significant decline in her intellectual function. She also had problems in speed of mental processing. This measures executive function or decision and problem solving, and this one measures memory. The speed of processing in the executive function improved at 2 years, but her memory never did improve back to normal. Just to give you a sense of this woman, this is a brain scan taken in the ICU. Again, this is the top of the brain, so we're looking from the front of the brain back. This is the temporal lobe we talked about. Here are the ventricles we talked about for looking for brain integrity. And all these really bright white areas are what we call hyperintense regions. It usually indicates at this stage that there's too much fluid in the brain. And we've always thought that once the fluid's removed that there's not going to be any problem. Well, this is her brain scan 2 years later. And if you compare the structural, notice there aren't very much fluid between the bumps of the brain. Look at how much increase in fluid there is. The ventricles have gone from a very normal size to much enlarged. Here's the temporal lobe, right here's her hippocampus. She also has changes in her cerebellum. So this illustrates that these fluid changes that we see early in the brain may be damaging the brain cells, which later die and then get removed. And so she has lost a substantial amount of brain tissue. She tried to go back to work, was not successful, and ended up taking an early retirement. So a couple of things that we know about critical illness and cognitive function. The case I showed you has shown there's an increased risk for having cognitive problems after you've been sick. About 40% of patients that are admitted to an ICU become critically ill and go on mechanical ventilation, the breathing machines. 33% of those will develop permanent neurocognitive impairments. And some ICU populations, we think the number is even higher than this. ARDS is acute respiratory distress syndrome. It's a syndrome where your lungs fill up with fluid and quit working. And in that case, you're really quite ill. And in those patients, the range is between 78% at hospital discharge and almost half the patients 1 year later. And another study at 6 years showed about 25% of patients still had severe cognitive problems. So looking at our first study, we were interested in how patients did. And this was the first study that was done in this area. And here's IQ, just like I talked about the IQ test, an average is 100, plus or minus 15 points is normal. And so you can see that the average IQ that we measured at hospital discharge was about 90. It's in the normal range. And then at 1 year and 2 years, it improves to about 100. There are some methods that we can estimate what your IQ test is before you come in. None of them are very good, but it gives us a ballpark about where you were functioning before based on your age and your education level and what your job is. And so you can see based on this estimate that it looks like most of their intellectual function recovered over time. However, if we look at other cognitive functions like memory, executive function, your ability to pay attention, we can show at hospital discharge, as I said, 78% of people had cognitive problems, and about 46% still have residual problems at 1 year. And if you look over time, at 2 years, there's really not much improvement or change. So the recovery seems to occur early and seems to stabilize quite dramatically. If we look at the types of cognitive processes, so this is mental processing, speed, memory, executive function, attention, and this is your intelligence quotient. And then the dark blue bars are when they're just after they leave the ICU before they leave the hospital. This is the scored bars are 1 year, the yellow bars are 2 years. You can see improvement from the hospital test, but you see somewhere between 35 to 37 or 8% of processing speed, memory, and executive function remain 1 and 2 years later. Now, if you think about trying to do your job, do you ever have to remember things? Do you have to make decisions? Do you have to be able to come up with critical thinking and process things? These are the areas that are most impacted in these individuals after the ICU. Just to give you a sense of how dramatic some of these cognitive impairments are, this is a standard test that we give patients who, for a variety of disorders, whether it's traumatic brain injury or critical illness, and we show them this figure. This is called the Ray-Ostrus complex figure, and what we do is we leave it there and we have them draw a copy of the figure, and they have the figure sitting there that they can look at the whole time. When we do that, this is what the patient drew. And you can actually see that the figure's not bad. There's a little bit of distortion, but overall, they've got most of the elements of the figure. Looks pretty good. So this would be considered a normal copy. Well, then what we do is a little bit mean. 30 minutes later, without warning, we say, do you remember that figure we had you draw 30 minutes ago? Could you draw it again for me from your memory? And this is what the patient drew. So you can see dramatic loss of information from memory. This is a nonverbal example, but the same is true for verbal examples. So if you gave them a list of words, they would remember the words immediately, but if you asked them later, they would have problems over time. In the same group of patients, we also looked at brain imaging findings. This is a 36-year-old woman. She actually went in for an elective surgery, had complications, ended up in the ICU. This is a normal individual, a control person, and here's her brain. Again, the front of the brain, back of the brain. These are the ventricles. Look at the difference in size. They're taken at the same level in the brain. So we can again see that we're losing brain cells or neurons in this individual. At 36, that's not very old. This is a 54-year-old male. Again, the front of the brain, the back of the brain, this is a normal control. Here are this man's ventricles. So he's losing a large amount of brain cells that corresponded to the type of cognitive impairment that they had. In our lab here at BYU, we can actually go in and measure this, and we do volumes for different brain structures. Here we're measuring those ventricles, and if you're losing tissue, the ventricles are getting bigger because you get more fluid filling in the space. And so the lateral ventricles, you can see, are substantially bigger than normal controls, which are yellow, and the total ventricle volume, the same thing. So we can show quantitatively that not only does it look like they're losing cells, that when you actually measure the structures, we have a massive loss of brain cells in these individuals. This is an example just to show you a 22-year-old that was in the same study that I was talking about. Again, this is the front of the brain, the back of the brain. These are the ventricles. This is her brain while she's in the hospital. So in this case, because she had several brain MRIs, we can use her as her own control. And then we followed her at 1 year and 2 years. And if you compare the size of her ventricles while she was sick compared to after, again, you can see that marked increase in size of the lateral ventricles indicating cell loss. We can show, again, here are the ventricles from another view. Look at the marked increase at 1 year and 2 years. And then this is where the hippocampus is, that structure I told you was critical for remembering new information. If you look over here, it's markedly shrunk, and this white spot above it is part of the ventricle system, and that's full of fluid. And in this version, the fluid is dark, and this is at 2 years. So not only do we have generalized brain atrophy, we have atrophy of some specific structures, the hippocampus, which is involved in memory. This is a view, again, that mid-sagittal view. If I cut my brain in half, this is the corpus callosum that connects the right and left side of your brain. Here is her corpus callosum at 1 year. Look at how much thinner it is. The same thing at 2 years, showing that we're losing the connections between the two hemispheres in the brain, which were related to her cognitive problems. She was actually very interesting. Her primary language was Spanish, her secondary language was English, And after this event, she was able to understand Spanish, but she couldn't speak it. She'd respond in English. So her family would say something to her in Spanish, and she'd respond in English. So she even lost part of her primary language. Well, other kinds of questions we were interested in: if so many patients have cognitive problems, what about other kinds of real-world things might be happening to them? And so when they would come back, we'd ask them if they had worked before, were they back at work, or were they on disability? And you can almost divide this group of 70 patients into thirds. A third had returned to work, although not all of those full-time. A third had new disability since the critical illness, which means they're now not providing for their families, they're on disability insurance. And a third were either not working or retired. About half of those were new retirements from the critical illness. So there's a substantial impact on the patients and their families. Well, one of the questions we asked, is it just this one study that we did in Utah, or is this more widely distributed? So as we showed, we had some improvement. Other studies have shown longer. So we looked at all the studies that have been done, and these have all been done since our study that was published in 1999. There were 11 studies. There are a couple more now in press. 7 studies were in the population with acute respiratory distress syndrome. 4 studies are just in patients that end up in a medical ICU for any reason who go on mechanical ventilation. And we excluded people that had prior cognitive problems like Alzheimer's disease, dementia, prior strokes, multiple sclerosis, and then they were all given neuropsychological tests to measure their cognitive function. This just shows across the studies. Most studies followed people quite early. This is 1-year follow-up. Here's our 2-year follow-up, and there are 2 studies, one that we've now done and the German group, that have followed patients beyond 2 years after coming out of an ICU. If you look at the average age across studies, the average age is 45 years. Think about this. These are not the elderly. These are not people that you would expect to be having cognitive problems. These are individuals in the prime of their career that are in these studies. And all studies included all ages, but we don't find as many elderly patients in our studies, and we'll come back to that in a minute. But if you look, the average age, and it's getting younger as I get older, is quite young in this population of studies. If you look at studies that included people that are over the age of 60, some studies included about 20%. And the study at Vanderbilt, there's a new study going on that's really targeted patients that are over 60 to see if their outcome is different. They have a much larger, about half of their patients are in this age group 60 and above. So the early studies did not find this. We've been targeting them. One of the reasons we think this is true is because many older patients don't survive their critical illness experience. This is the rate of cognitive impairment across studies. So the dark bar is just how many patients were in a study, but the percent of impairment ranges from 80%, this is at hospital discharge, and then the 46% is at 1 and 2 years, the study I showed you just a minute ago. And then the range goes anywhere from 20% to up into the 70s. But what we can see is consistently every single study has shown that if you're in the ICU on mechanical ventilation, a proportion of patients have permanent cognitive impairments after they leave the ICU and recover, which is quite novel and unique. If you look at just the elderly patients, you can see that this is one test at this is a 3-month test and this is a 9-month test. If they have one test that's abnormal, it's over 50%, and then at 3 months it improves, which is what we would expect. And then if you have 2 or more tests, the rate is about 30%, so this is 2 or more cognitive domains, so this might be only memory, but this could be memory plus executive function or plus attention. And again, you see some improvement, but a substantial number of patients over 60 years old also have cognitive impairments that we see. If you look at all the studies lumped together and just look at the frequency of what types of cognitive function are impaired, the most common impairments occur in memory, executive function, and attention, and then how quickly you can think, mental processing speed, your IQ, or visual spatial skills are also impaired, but to a lower rate, which may be partially due to what the different studies measured. But you can think about this. If you think about two of the things you use every day are your memory and your ability to make decisions, plan, and organize. And those are the most frequently impaired, all 11 studies for memory, 10 of the 11 studies for executive function. So these are substantial impairments in individuals' lives. And I'm going to skip that because we've looked at the data. So we were interested in, might there be something that would cause people to be more likely to have cognitive impairment? So we looked at risk factors. And we thought, well, how sick they are would be a logical risk factor. So there are ways that we can measure how sick you are or illness severity, how long you're in the ICU. There's a score called the Apache 2 score that takes a bunch of physiologic measurements and tells us how sick you are or how long you're on a ventilator. We didn't find any relationship between those obvious markers of illness severity. Pre-existing cognitive impairments were excluded in all the studies, so that doesn't account for the cognitive impairments. These findings were a little surprising. We also didn't find age being related. Now, if you remember, I told you the average age was 45. That's probably why, because there weren't enough elderly patients or a large enough distribution to really see if there's an age effect. And so the newer studies that are targeting the elderly population are quite critical to answer that question. We also were interested in what are some possible mechanisms. What would be causing this? Is it just the fact that you're sick or in the ICU? Is it the fact that your lungs aren't working well and you're not getting as much oxygen, which we call hypoxia, low-level oxygen, anoxia, no oxygen, ischemia, low-level blood flow to the brain? Is it inflammatory mediators because many of these people have infections, sepsis, a systemic infection? Is it because their blood glucose is out of regulation? And there's a whole host of postulated mechanisms here that I don't have time to talk about, but I am going to talk about a few that we've looked at. This is a 52-year-old female. Actually, she's the wife of one of my very close friends. She got septic, or a generalized infection, from dental work that she had. She developed tremors. She developed cognitive impairments. And because of having serial MRI scans, here's her scan in 2003. Looks pretty normal, a little bit of ventricular enlargement. Here's 2005. Here's 2006. And this really bright area over there is not normal. That's a new infarction from being critically ill. You can see, excuse me, on the bottom picture, we've taken this area that's bright in this one, and this is a PET scan which looks at blood flow. And if you have good blood flow, the colors should be bright yellow, even bright red. You can see a few areas of bright red. Here's the area where the infarction is. Blue means very little blood flow. And if you compare the size of the infarction here with the area that has reduced blood flow, it's actually not just the infarction, but it's the surrounding area that doesn't show up on the brain scan. So we know that there's decreased blood flow to those areas as well. She also ended up having a few lesions. They're little tiny white spots. This is actually in her motor system, which probably accounts for the tremors she got. Also here in the cerebellum, which is involved in movement, particularly fine, control of fine movement. And then this is her scan 2003, 2005. All these extra bright areas in 2006 show damage to the temporal lobes, which, as I mentioned before, are important for memory. So we believe that sepsis and infection play a role. As part of our study, the first study I talked about, where we measured 72 patients, the technology allows us to look at their blood oxygen level across time. You can put a pulse oximeter, a probe on your finger, And we electronically capture that data every 15 minutes. We capture a floating median, so we average the measurements over 15 minutes. And we can look and see whether their blood oxygen level is normal. And in this case, less than 90% doesn't sound that bad, but that's a blood oxygen level of about 50. At altitude where we all live, ours is somewhere between 85 and the low 90s in a normal, healthy person. So having a blood oxygen level of 50 is substantially low, and we could calculate how much time they were down, because if we had 2 measurements that were below, we counted that as a 15-minute interval, and the average person in the ICU that we were aggressively treating had almost 120 hours that their oxygen level was below 50. And when we looked at the relationships to their cognitive outcome, it was related to poor memory, impaired executive function, and attention. And we did this in our new 6-year study, and we found similar things in a second population of ICU patients. We also looked at blood pressure because obviously blood flow might contribute to this, and so we look at a mean blood pressure, which is an average blood pressure, and it's taken not by a cuff on your arm. There's a measurement that they put in your artery and measure that. And if you had a mean blood pressure less than 60, which is too low, it was related to memory impairments at 1 year. So these physiologic measures, even though we're aggressively treating them in the ICU, are related to your poor cognitive outcome when they're below normal. We also looked at glucose regulation. If you think about glucose and like diabetic, how important it is to have a normal blood glucose level, because it causes all kinds of problems. People are more prone to infection. They can start having damage to neurons, particularly eyes and feet. And in the ICU, because of how we treat patients, their blood glucoses are going all over the place, even in non-diabetic patients. And so we measured this. A normal blood glucose is about 120. And we measured the time that their blood glucose, so 60 to 110 is normal, 120 is the upper end of normal. We measured this for the amount of time it was above that. We don't have very many measurements below. And what we found is that if your blood glucose was out of the normal range, and particularly if it was bouncing up and down, so it goes up, we try to control it, and it comes down, then we have to give you some glucose because we get it too low, and so it's bouncing up and down. That variability contributed to the cognitive problems that these individuals are experiencing 1 and 2 and up to 6 years after they've been discharged from the ICU. The other thing that happens when you come into an ICU, to keep you comfortable, we give you a lot of great sedative and narcotic drugs. And one of the things that we know is they contribute to the development of delirium. Now, delirium is always thought to be a transitory effect, that you get sort of out of it, you're confused, you're not able to focus, and that once you get better, that's going to go away. Well, Wes Ely's work at Vanderbilt has shown about 80% of patients in the ICU get delirious, which is quite high. About 20 to 50% of patients on just a medical floor in the hospital get delirious. This is particularly true in those individuals over 60. And about 30 to 40,000 patients in the ICU in the United States today are delirious across the country. We were interested in, does delirium cause problems? Because we know if you're delirious in the ICU, you have a higher mortality rate, you're in the ICU longer, you're on a ventilator longer, you have more ICU-related costs. And so we did a literature review to look at this, and most of these studies were in elderly patients, and we found that in elderly patients, delirium was related to either development of cognitive impairment or becoming demented within a year after leaving the hospital. The study at Vanderbilt showed that critically ill patients, 1 in 3 with delirium, had cognitive impairments. So delirium, that many people have considered benign and just a marker that you're sick, and when it goes away, everything's going to be okay, there are hints that delirium might not be as benign as we thought, that it might cause permanent problems later on. This is not an ICU study, but many people that end up in the ICU have other comorbid conditions, in particular things like diabetes, heart disease, pulmonary disease, And so the question is, well, it's really not the ICU, it's really all these other things that the patient already had before they came in. And so this is a very interesting study done by Hillesbeck, and they actually have 3 groups. So group 1 had hepatitis C only, group 2 had hepatitis C plus other chronic illnesses, and group 3 had hepatitis C plus liver disease. And liver disease is known to have cognitive problems, so you might expect that that might be the group that had the worst problem. Well, if you look at the group that has the worst cognitive problem, this is memory. This is that diagram that I showed you to remember. Anywhere between 9 to 46% of people are impaired. Digit span is attention. This is executive function. The highest rate of cognitive impairment occurred in the group that had comorbid disorders before. So there is some suggestion to suggest that if you have cardiac disease, hypertension, diabetes, pulmonary disease, particularly if it's not controlled, this may be a risk factor for worse outcome, although the study has not been done in ICU patients. Well, there are many studies going on to try to improve survival in the ICU patients, and this is one that was funded by the NIH that was a multi-center study, and they were comparing fluid dose. So when you come in, if you're hypotensive and your blood pressure drops, we give you fluid to raise your blood pressure. And so they were comparing normal fluid dose, which is a lot of fluid to get your blood pressure up, with a conservative dose of fluid. And what they found is they didn't find any mortality difference. Well, as part of this study, my colleagues and I at University of Pennsylvania said, well, can we look at cognitive outcome in these patients? And that's what we did. So we prospectively followed these patients and looked at cognitive and psychiatric outcomes for 12 months. And you can see here is the liberal fluid group, here's the conservative fluid group. The people that ended up in our study, now this is a subset and it's small, these are the people that agreed to be in our study, and then 46 completed testing in one group and 56 in the other group. We find in this new group of patients across multiple centers, there are 12 centers involved in this study, the same thing that we saw in the previous study. If you look at both groups combined, about 15% of patients have memory impairments or language problems, and almost half have problems with executive function, decision-making, planning, organized. If we compare the 2 fluid arms, so liberal is the L, conservative is the C, we actually see that those that got the conservative fluid, the dark bars, this is executive function, this is memory, and this is a global cognitive impairment, had worse cognitive impairment than those in the conservative arm. Now, this may seem surprising to you because they didn't find a mortality difference, but historically there have been treatments that preserve life but cause problems. So actually, heart surgery is one of those. If you have coronary artery bypass graft surgery, you have better life expectancy, you live longer, you feel better, your quality of life improves, but a subset of those people have some cognitive, particularly memory problems, after having the surgical procedure. So in this case, there was not a mortality difference, but this small group suggests that sometimes a strategy that we try to improve one kind of outcome may negatively impact another kind of outcome. Because this is only a small subset, we need to be very careful in how we interpret this. So the question is, if we think about this, what does critical illness do? And this is a diagram that I've adapted from Bob Hill, who's at the University of Utah. So this is his successful aging, his normal aging, impaired aging, and decreased aging. This would be a dementia group. And if you have critical illness that happens somewhere along your aging trajectory, what does it do? Well, we're hypothesizing that what it does is shift the curve so that those that were having successful aging may have normal or impaired aging, and those that were having impaired aging now may have substantial problems overall. And hopefully the study at Vanderbilt will help address this question. I hinted about functional outcomes after critical illness, and we're just about out of time here. But if you look at my study, remember it was the study of thirds. A third were working, a third were on disability, a third were not working or retired. If you look at working, not working, this is a study from Vanderbilt. It's even higher. It's about 50-50. This is a study from Toronto, Margaret Herridge. Again, it's about 50-50 or working or not working. And this is from Pennsylvania, showing that many of these people don't return to work again in the prime of their careers. So there's a significant impact of critical illness on the ability to support their families. If you look at functional implications, many of these patients, as I said, are unemployed, they're unable to drive, their executive functions impairing their ability to manage medication, get themselves around. There are studies that show that they have a decrease in all functional levels, performance and activities of daily living. Those are things like dressing, toileting, eating, and then instrumental activities of daily living, which are here. Those are things like money management, finances, driving, being able to take care of, shopping, grocery shopping, cooking. The study by Jim Jackson at Vanderbilt showed almost 20% or more have problems with basic functional activities around the house after the critical illness. We also know that it's not recognized. It's not recognized even in hospitals, even on rehabilitation units. Of our study, 31 patients were referred to the rehabilitation unit. Most of those were for physical rehabilitation. Only 9 had their cognitive function assessed to see if they had needed cognitive rehabilitation. In ICUs, even delirium is not recognized as much as 90% of the time. And if you think about Wes Ely's data that say 80% of people are delirious, there's a lot of people whose delirium is not recognized by people in the ICU. It's overlooked in critically ill patients, and I've already said many don't return to work. If we look at quality of life, what happens to these individuals? Well, this is a review paper from Dowdy and Del Needham at Johns Hopkins, and actually my data is in here, so it's the triangle data where we look at quality of life. What they found is that across all these studies that measure quality of life in survivors of critical illness, that quality of life scores are lower than the normative data for the patients their age. It's very domain specific, so the domains that measure physical function improve in the first 6 months. Beyond 6 months, quality of life does not improve, and there were persistent but important decrements compared to the general population, in particular in mental health domains. So we've talked about costs. The support study showed that family members, 20% have to quit work to take care of their family member, 29% lose a major source of income to support the family, 31% lose their family savings in individuals that are in the intensive care unit. We also know that if you have cognitive impairments, this is not ICU data, but if you have a mini mental status score, which is just a screening test that drops 3 points, it increases your health care costs by $6,000, and your cost to the family is somewhere between $15,000 and $35,000, and these are 2002 data. 50% of critically ill patients require caregiver support for at least a year. So not only is the patient impacted, but their spouse or caregiver is also impacted, and it has a huge impact on families, resulting in an $18 billion estimate impact to the United States economy. So in conclusion, cognitive impairments after critical illness are common. Some people improve from 6 to 12 months. They seem to be permanent out to 6 years. Risk factors and mechanisms are under study. They have significant functional implication. The effects of ICU interventions are just beginning to be studied, as are interventions after the ICU to remediate or rehabilitate these impairments. So critical illness can lead to adverse brain-related outcomes, and these are a few of my collaborators. Thank you.